Let's dive straight into the clinical pathways you'll be using every single day on the wards. We're breaking down high-yield lower gastrointestinal pathologies in this explainer, focusing heavily on the exam-facing decision logic you need as a third-year medical student. We're going to cover everything from appendicitis and bowel obstructions to strict lower GI bleeding workups, making sure you understand the chronology, the mechanisms, and exactly how these conditions present in real life.
Section 1. Right lower quadrant pain and appendicitis.
Typically, your patient is going to start off complaining of this vague, annoying pain right around their belly button. This initial discomfort is coming from visceral afferents. It's diffuse, poorly localized, and often comes along with anorexia, nausea, maybe some vomiting, a low-grade fever, and mild leukocytosis. But as that inflammatory process ramps up and starts involving the parietal peritoneum, the pain definitively localizes to the right lower quadrant. To pinpoint that inflammation on a physical exam, we're looking for McBurney point tenderness, involuntary guarding, and rebound tenderness, all of which scream peritoneal irritation. Now, a classic test-style question is going to test your anatomical knowledge using specific maneuvers to figure out the exact location of the appendix or a resulting abscess. For instance, the psoas sign, that's right lower quadrant pain when you extend the right thigh, points to an abscess right up against the psoas muscle or a retrocecal appendix. The obturator sign, which is pain with internal rotation of the right thigh, points toward a pelvic appendix. And then you have Rovsing's sign, where deep palpation of the left lower quadrant actually causes referred pain in the right lower quadrant that is a classic, undeniable indicator of acute appendicitis.
Once you suspect appendicitis, you've got to choose the right diagnostic imaging, and that choice is driven entirely by who your patient is. For non-pregnant adults, you go straight to an abdominal pelvic CT scan. It's going to give you the absolute highest sensitivity and specificity. But children and pregnant patients are a different story. They must start with a graded compression ultrasound so we can avoid unnecessary radiation exposure. If that ultrasound is non-diagnostic, then you move to an MRI. It's also highly testable to remember that during pregnancy, the appendix undergoes cephalad displacement. It literally gets pushed upward by the gravid uterus. This means a pregnant patient might present completely atypically, with pain in the right mid to upper quadrant or even the right flank, which can completely mimic conditions like cholecystitis or pyelonephritis.
Once the diagnosis is locked in, the management splits. And here is a massive exam day exception you need to know. If the patient has non-perforated appendicitis, the treatment is totally straightforward: broad-spectrum antibiotics and an appendectomy within 12 hours. But if imaging shows a contained abscessial abscess, you do not rush them to the operating room for an immediate appendectomy. Operating on a highly inflamed, friable field with a contained abscess drastically increases the risk of spilling infection and causing a much bigger mess. Instead, this patient gets treated initially with IV hydration, antibiotics, bowel rest, and, if it's large enough, CT-guided percutaneous drainage. They are managed conservatively first, and then usually returned for an interval appendectomy weeks later, once all that inflammation has totally cooled down.
Section 2. Pseudoappendicitis, specifically infectious ileocecal.
Because listen, not everything that looks like appendicitis actually needs a surgeon. Infectious ileocecal, which is often caused by Campylobacter or Yersinia enterocolitica, presents remarkably similarly to appendicitis with fever and right lower quadrant pain. But your key differentiators here are going to be found in the patient's history and the specific type of gastrointestinal distress they're having. If the patient has prominent mucoid or bloody diarrhea, a history of sick contacts, or they recently ate undercooked poultry, you're likely looking at a self-limited pseudoappendicitis. In these cases, the inflammation is mostly localized in the terminal ileum and cecum. Management here is primarily supportive care. Antibiotics are strictly reserved for severe cases, high fevers, profoundly bloody stools, or high-risk patients like the elderly, pregnant individuals, or anyone who is immunocompromised.
Section 3. Small bowel obstruction versus postoperative ileus. When you have a patient presenting with abdominal distension and vomiting in the hospital, we frequently have to definitively separate a mechanical small bowel obstruction from a postoperative ileus. Radiographically, a small bowel obstruction is going to show dilated proximal small bowel loops, distinct air fluid levels, and a very clear transition point, literally an abrupt cutoff, with little to no colonic air distally if it's a complete obstruction. Now, if it's just a partial obstruction, you might still see some scattered air in the colon. This contrasts sharply with an ileus. An ileus is characterized by the global dilation of both the small and large bowel. Crucially, an ileus has no clear transition point at all, and you'll typically see air present throughout the entire colon and right down into the rectum, which reflects a generalized paralysis of the whole gastrointestinal tract.
Clinically, these two presentations diverge pretty sharply as well.
A small bowel obstruction causes colicky abdominal pain, obstipation if the obstruction is complete, and hyperactive, high-pitched, tinkling bowel sounds early on that may eventually become totally absent as the bowel fatigues. The most common cause in the US by far is surgical adhesions from a prior abdominal surgery, and that surgery could have been weeks or even decades ago. An ileus, on the other hand, typically happens hours to days after a very recent surgery. In a clinical vignette, keep an eye out for the patient who is 24 to 48 hours post-op and receiving heavy opioid analgesia. An ileus is also often triggered by electrolyte abnormalities, especially hypokalemia, or things like intra-abdominal inflammation, hemorrhage, or pancreatitis. Because it is a paralytic state of the bowel, you're going to hear reduced or completely absent bowel sounds right from the onset, along with abdominal distension and a complete failure to pass flatus.
For a small bowel obstruction, your initial management is going to be supportive. You order bowel rest, place a nasogastric tube for decompression and suction of those backed up gastric contents, and aggressively administer IV fluids to correct the hypovolemia caused by fluid third spacing right into the bowel lumen. However, you've got to watch these patients like a hawk. Immediate, urgent surgical exploration is absolutely required if you see any signs of clinical deterioration that point to bowel ischemia or necrosis. These definitive triggers include new-onset fever, hypotension, tachycardia, signs of peritonitis like focal guarding or rigidity, or any imaging evidence of strangulation and perforation.
Section 4. Lower GI bleeding workup logic.
Here is a non-negotiable rule for the wards. Any new iron deficiency anemia discovered in an elderly patient mandates both a colonoscopy and an upper endoscopy, period. Microcytic anemia in this specific demographic heavily points toward occult gastrointestinal blood loss, and your number one concern is malignancy. While benign issues like hemorrhoids can definitely cause mild bleeding, they rarely generate sufficient, sustained blood loss to produce an actual iron deficiency anemia. So a thorough endoscopic evaluation is required to track down potential right-sided colon cancers, which typically bleed insidiously without obvious red blood or gastric malignancies.
Now, what about a super common complaint like minimal bright red blood per rectum? Think blood noticed just on the toilet paper. The logic here relies entirely on the patient's age and the presence of red flags. If a patient under 40 comes in without any red flags, they get a simple anoscopy to evaluate for suspected hemorrhoids or anal fissures. If you identify a source right there, no further extensive workup is necessary. You just treat the local pathology. However, if the patient is aged 50 or older, you skip the anoscopy entirely and proceed straight to a colonoscopy, regardless of whether you suspect hemorrhoids. At that age, the underlying risk of colorectal cancer completely overrides a simple localized exam.
But you've absolutely got to know the red flags that instantly change this entire decision tree. If a younger patient, someone well under 40, presents with minimal rectal bleeding but also has unintended weight loss, iron deficiency anemia, significant abdominal pain, a family history of early colon cancer, or a recent change in bowel habits like new-onset diarrhea or constipation, you completely bypass the anoscopy. These alarm features demand an immediate colonoscopy to rule out structural changes, inflammatory bowel disease, or colorectal cancer.
Section 5. Perianal masses and diverticulitis. When you're trying to differentiate perianal masses, rapid pattern recognition is your best friend. An external hemorrhoid is intensely painful, especially when it becomes thrombosed, presenting as this tense, bluish nodule located below the dentate line. In contrast, an internal hemorrhoid typically just causes painless, bright red bleeding. If you examine a patient and find a fluctuant, erythematous, and highly tender mass, accompanied by systemic signs like a fever, you are dealing with a perianal abscess. That requires imaging to define the extent and prompt surgical drainage in the operating room. A rectal prolapse will appear as a concentric ring mass that protrudes when the patient performs a Valsalva maneuver. Finally, anal cancer is going to present as an enlarging, firm, ulcerating mass that may be associated with HPV infection or HIV.
Moving slightly higher up the GI tract, let's talk diverticulitis. This classically triggers left lower quadrant pain, fever, and leukocytosis, usually in patients with a history of heavy meat consumption and low dietary fiber intake. Diagnosis is confirmed with a CT scan showing colonic wall thickening and fat stranding. While small, uncomplicated cases respond totally fine to IV antibiotics and bowel rest, your focus on exams needs to be on recognizing severe complications. For instance, if a CT shows a fluid collection greater than 3 to 4 centimeters, that indicates an abscess, requiring CT-guided percutaneous drainage. Another super high-yield complication to watch for is a colovesical fistula. This is a connection that forms between the colon and the bladder,
and it presents distinctively with pneumaturia, literally air in the urine, or fecaluria, along with recurrent, mixed flora urinary tract infections.
Section 6. Ischemic colitis and a clinical recap.
To wrap up our lower GI pathology framework, let's look at ischemic colitis. This strikes older patients who have established vascular risk factors, and it almost always happens after a state of transient hypotension, like during a major surgery or an episode of sepsis. It manifests as sudden crampy abdominal pain, followed very quickly by bloody diarrhea. The ischemia typically localizes right to the watershed areas of the colon, specifically the splenic flexure and the rectosigmoid junction, because those spots are incredibly vulnerable to hypoperfusion. And that compactly caps off our high-yield review. We have mapped out exactly how the vague pain of appendicitis transitions to the right lower quadrant and the precise imaging rules based on patient demographics. We definitively separated a mechanically blocked small bowel obstruction requiring close surgical watch from a supportively managed paralytic postoperative ILIS. And finally, we locked down the strict rules for lower GI bleeding, ensuring that any red flags or new iron deficiency anemia in older adults triggers an immediate endoscopic search for malignancy. Ensure you have these exact criteria locked in for the wards.